Well, welcome to today's postgraduate seminar. So over the last several months we've been dealing with microbes and really the molecular biology of how they function. And over the next several months we're looking at a different theme, which is now microbes and the host population dynamics. So this will sort of include things like the epidemiology of the reservoirs, how infections are spread, and today particularly we'll be looking at how microbial, or the drivers of microbial resistance come about. So it's a great pleasure to have Lindsay Grayson here today to give us this lecture. So Lindsay actually completed his infectious diseases training in Harvard, and then he went on to do a master's in clinical epidemiology in Harvard. And then he came back and was director of infectious diseases at the Monash Hospital. And now he's the director of infectious diseases and microbiology at the Austin Hospital. And he was the former president of the Australian Society of Infectious Diseases. And he was also the head of the training committee on infectious diseases in Australia. And he still is the chair, I think, of the program committee for the Interscience Conference on Antimicrobial Agents and Chemotherapy. So he's done a lot of work on MRSA, the superbugs, Vancomycin-resistant enterococci, and also the extended beta-lactamase producing gram-negatives, the outbreaks that happened in Australia, trying to understand how they all came about. So it's great to have him here today to give us this lecture.
Well, thank you very much, Mark, for that kind invitation and introduction. So what I've given, we were debating about what title we'd call this today. One could call this bed to bench to bedside, and I include that specifically because I think a lot of the important things we do are actually start with a clinical problem, and it's later that you move to the fourth gene on the left, issues with it, but it starts with a clinical problem. But another title would be, are antibiotics dead? And if so, how can we manage? And so by way of overview, I thought I'd give you a view from Mars about or an outside view of the current problems, and discuss some of the basics of the solution, perhaps some practical steps in hospitals, and then focus particularly on vancomycin-resistant enterococci as a sort of a case study of some of the issues Mark was just raising in terms of combining epidemiology, clinical infectious disease, and then lab investigation of those problems. So if we're sitting at Mars, some of you're all too young, but there used to be an old television show called about My Favourite Martian, and this was the guy, or maybe it's like this, and you're looking down on the Earth, and you'd say, well, you know, I don't know how many of you realise, but penicillin was only first introduced in the early 1940s. So prior to that, there were sulphurs in the early 30s, but prior to that, there were no antibiotics. So in other words, my mother was born in 1928, and during all of her teenage years, there were no antibiotics. So they're invented and penicillin is used from 1940s onwards, and in fact, there are some estimates that it reduced the number of troops needed to retake Europe by about 10%, and that's why the Allies could do it ahead of time to what was originally predicted. But in the space of 70 years, we've now gone from not having these products to having them, but potentially having wasted them, such that we're now seeing, last year we had 4 patients at my hospital die with multi-drug resistant pathogens that we simply couldn't treat because they were resistant to every antibiotic we had. So if you were sitting on Mars and you saw a species such as the human race, and that went from having no antibiotics to inventing them and then wasting them in the space of 2 to 3 human generations, you might question what sort of species that was. And so we've already seen the rapid emergence of multi-drug resistant and gram-positives, whether it's MRSA or methicillin-resistant Staph aureus, vancomycin intermediate Staph aureus or Visa, vancomycin-resistant enterococcus, as we'll talk about shortly, linezolid-resistant enterococcus, which is linezolid is one of the last line drugs we have. In gram-negatives, it's a particular problem with metallo-beta-lactamases and even now colistin-resistant gram-negatives, and this has now entered the food chain, and we'll discuss this shortly, but this is a major problem. XDR-TB, which obviously here you know a lot about, and in the hospitals more recently in Melbourne, hypervirulent C. difficile or Clostridium difficile. So if you're a Martian, you'd say, well, this can't be right. No one could be this effing stupid. Perhaps you should take me to your leaders. So if we look at our leaders, whether they're those in power or those who claim to want to be in power, most of them come from a non-scientific background. They've either specialised in commerce or law, and the last time they did any science was probably year 9 or 10. And so it's a tough ask to expect them to understand. Maybe if we go internationally, well, perhaps there's not much hope there either. And sometimes it even gets kind of desperate as to getting anyone to understand. So, as a Martian would say, well, as a species, I think you probably are screwed. So, however, if you go back to what were the major advances in terms of controlling infections, it actually had nothing to do with antibiotics. The three key steps were improvement. They're all engineering achievements, actually. So there's improvements in sanitation, improvements in housing, both reducing of overcrowding and improving spatial separation of one person from another, and it was clean food and water. And if you look at those three components, in some way at least, that's part of the problem now with a lot of the way we produce food. In that if you look at, say, chickens, we've created chicken megacities of 10 million chickens on 3 acres with overcrowding, poor sanitation, poor water, and it's little surprise that there's now spread of multi-resistant genes, at least, if not bacteria, between these meat-producing animals, and that we then colonise our gut with these genes. And it's only later, of course, that hospitals were invented in terms of human health, and that the issue of reducing cross-transmission in hospitals became an issue. And I guess Florence Nightingale, was a key to this, that during the Crimean War and subsequently First World War, identified the issue of overcrowding in hospitals, and people often say, well, hospitals should be safe places, but in fact they're very dangerous places, because if you think about it, we take all the sickest patients and we crowd them together into one building, and then you wonder why there's cross-transmission. Well, a lot of this is pretty basic. And then, of course, on the bottom is Semmelweis, who was the get this to work. So Semmelweis, who pretty much sacrificed his life, he was the one who identified the importance of hand hygiene and the impact of that on reducing cross-transmission of bacteria, particularly group A strep in pregnant women. So there's finally, at the end of all this, comes along antibiotics, and it's through antibiotics and focusing on these other 4 issues that have allowed us to progress medicine to the point of intensive care units, neonatal intensive care units, cancer chemotherapy, immunotherapy and so forth. Without the antibiotics available, then none of those things are really possible. So if you look at an overview of the solution, well, there are 2 ways you can catch bugs. You can either limit cross-transmission of existing multi-drug resistant pathogens, or you can limit the emergence of new pathogens, and we'll talk about both of those today. Now, this is from another talk, but these are my 5 steps about controlling, practical steps to controlling things. And the first of these is improved hand hygiene, development of national standards for invasive device insertion and maintenance, improved hospital cleaning and hospital design, and then tightening antibiotic control. And of course, the first 4 of those are about reducing cross-transmission. And it's only the last of these which is about reducing the emergence of new resistance and colonisation. And there is not the topic for discussion today, but there is some confusion about how we approach this, because all the discussion is about antibiotic stewardship in hospitals and using antibiotics appropriately, and that is important. However, I would argue, in fact, that really, because of the spread of multi-drug resistance, particularly in the food chain in Asia, that time has passed. And our main problem now is stopping cross-transmission, because unless we stop aeroplanes flying into Australia, which is not going to happen, antibiotic resistance is here, and it's only going to grow. So, if we look at how do we control these various pathogens, it's important that you understand something about the epidemiology of the different pathogens, because that's going to impact on what's likely to work. So if we say, in terms of Staph aureus, for instance, that the epidemiology is that it's mostly cutaneous and nasal colonisation, and person-to-person transmission is from hands and shared pieces of equipment. Whereas with VRE or vancomycin-resistant enterococcus, it's more complex, but it's largely gut colonisation and then transmission from contamination of the environment. And similarly with multi-drug resistant gram-negatives, the Enterobacteriaceae and Pseudomonas, it's largely gut colonisation with then fecal oral transmission, essentially, and then becoming infected from your own gut flora or newly colonised. Similarly for hypervirulent C. difficile, started with inappropriate antibiotic use, probably inappropriate fluoroquinolone use such as moxifloxacin in the US, which led to the emergence of this bug, gut colonisation. Clostridia produce spores, so once the environment becomes contaminated with these multi-resistant spores, unless you're using bleach or something that's going to destroy Clostridial spores, then your hospital becomes chronically contaminated and you've got a problem you can't get rid of. At the Beth Israel Deaconess Hospital, where I worked in 1989, if you entered the vascular ward there, you only have to be there for 5 days before you had a 70% chance of picking up Clostridium difficile. Why? Because the whole environment, the door handles, everything was covered in Clostridial spores, and they weren't using cleaning agents that killed those spores. And then, of course, there are separate issues for XDR, TB, obviously respiratory transmission, but there's this, as you guys know here very well, this really toxic combination of immunosuppression with HIV, large bacterial loads, and then ready transmission with respiratory pathogens, with respiratory spread. So just to take the first example of my 5 potential solutions, and we're not going to go through all of them today, but you know, if you look at Staph aureus, this is why improved hand hygiene, particularly using alcohol-based hand rubs, has made such a massive difference to the issues of methicillin-resistant Staph aureus. We've been involved in the WHO program with the so-called 5 moments of hand hygiene. Alcohol-based hand rub has a dramatic impact on skin colonisation with pathogens such as MRSA, and because it can be put at the foot of every bed, 15 seconds gives the same sterilisation effect as 45 seconds of hand washing. Suddenly you've got a practical tool that can control person-to-person transmission. In our ICU, we've done surveys, and our ICU nurses need to wash their hands 26 times an hour if they're to do hand hygiene appropriately in ICU. Well, 26 times an hour multiplied by 45 seconds, that means half an hour of every hour is taken washing their hands, let alone the degradation of their skin using soap. Whereas alcohol-based hand rub is an effective way that they can actually alcohol rub, and the skin softeners which are in these new products can actually improve your skin integrity compared to soap and water. So we have, there's been a whole Australia-wide rollout of alcohol-based hand rub before and after every patient contact. And with that, recently we published these data about MRSA rates in Australia late in December last year. And here are the nationwide rates of Staph aureus bacteremia prior to the intervention for the national rollout of alcohol-based hand rub. So now we have 620 hospitals coordinated through the Austin, 620 hospitals right across Australia, all using alcohol-based hand rub, all being audited 3 times a year, all submitting their data to us, now going up on the My Hospitals website, so you can type in the Royal Melbourne Hospital, the Austin Hospital, and see what our last lot of compliance rates were, and maybe use that to decide whether you want to be managed at one of those hospitals. But you can see here that this typical narrowing of what happened, the same thing happened in Victoria, which we've published previously, where you see this steady reduction in the rate of Staph aureus bacteremia, let alone colonisation, and this was highly statistically significant in terms of trend and over that time period. So if we now move from that example of Staph aureus to now look at a gut coloniser like enterococcus, I suppose we could start by saying, well, what's the big picture with enterococcus and why has it become a problem? Well, enterococci are part of our normal gut flora. Because of that, they're the commonest cause of urinary tract infection, because most urinary tract infections, just because of the anatomy, are the bugs that are from your faeces. And so it's the commonest cause of urinary tract sepsis, particularly in women for obvious reasons, and also intra-abdominal infections. And that during the 1970s, there was this massive increase in the use or in the problems of enterococcus in hospitals, largely because of the invention of third-generation cephalosporins, which innately have no activity against enterococcus, so third-generation cephalosporins such as ceftriaxone. And so with the growth of the use of these new drugs, which were good drugs because they avoided the use of aminoglycosides, But with that, it left a niche for enterococcus to become a problem as a nosocomial or hospital-acquired pathogen. Combined with that, particularly in Australia, but all around the world, there were growing problems with methicillin-resistant Staph aureus, and essentially the infection control activities to control this pathogen were ignored. And in a sense, it's a national disgrace for Australia, the way in which, when I was training in the late 70s and early 80s, that in the end the decision was made, the cat's out of the bag, we can't do anything about MRSA, we'll just let it run. And because of that, there was a massive increase in the use of vancomycin for patients who are febrile and in hospital. We had to cover the possibility that they had MRSA. And so, much like the tick bird follows the rhinoceros, you found that the combination of enterococcus now being exposed to vancomycin, that we saw the emergence of vancomycin-resistant enterococcus, with the first report being at the Austin actually by Adiba Kamalruzaran, when she was a registrar there in 1995, and subsequently it's now become a major issue through all Australian hospitals, particularly down the eastern seaboard. And there's been a lot of similar discussion about, is it a cat out of the bag? Some clinicians would say, look, this is not a problem, it doesn't cause major issues, why should we worry about it? And I keep reminding them, well, this same discussion happened in 1982, and look what's happened with MRSA, and it's taken us 3 decades and many deaths and a lot of money for ill patients and suffering because we ignored this at the start. So a one-slide summary about VRE. Some of you may or may not know about this. So vancomycin-resistant enterococcus. The 2 commonest species of enterococcus are Enterococcus faecalis and faecium. About 10 to 15% of enterococcal infections are faecium. The others, about 80% are faecalis, and the final 5% are made up of a hodgepodge of about 16 other strains. Faecium is a pain, and the reason why most VRE are Enterococcus faecium is because they're innately resistant to penicillin. Their standard MIC is 4 to 8, and so you have to use high dose to get activity. But with that, with VRE at least, there are a bunch of different VAN genes. A and B are the 2 commonest. VAN A denotes resistance to both teicoplanin and vancomycin, so they're both glycopeptides, whereas VAN B, they're resistant to vancomycin but often still sensitive to the alternative, teicoplanin. The problem is that teicoplanin is a pretty crappy drug and doesn't get very good penetration into deep-seated infections, and so it often fails. So we know there's a fair bit of research has gone into this, epidemiology, so that VRE fecal carriage, so just carrying it in your faeces, not causing any problems, occurs in about 2 in 1,000 healthy Australians. There's about 1% of outpatient dialysis patients carry a VRE in their poo, 3% of general inpatients, and a bit more than that amongst nursing homes. Nursing homes are a big problem because we're sending sicker and sicker people home to nursing homes, and yet the standard of healthcare there in terms of infection control is less than what it would be in hospital. And so in a way it's sort of a cross between a third world country and a feeding lot in terms of the spread of bacterial pathogens. So we know that for about every 10 to 20 colonised patients you'll get 1 infected patient. So if you find you've got someone who's got an infection, so some years ago we identified a patient when I was at Monash Medical Centre who had a VRE urinary infection. So we then screened all the patients for some period because we expected to find a whole, sort of the iceberg below the water, if you like, of all the colonised patients. And sure enough, there were about 20 colonised patients for that 1 infected patient. So there is a formula there, and of course that formula, whether you have 20 colonised to each infected or 5 colonised to each infected, depends on the population you're talking about. So say, for instance, our haematology oncology patients, we only need about 4 to 5 colonised patients to get a bacteremic patient. Why? Because when they're given cancer chemotherapy, it causes ulceration of their gut mucosa as part of the side effects of that drug therapy. The drug therapy is designed to kill rapidly dividing cells. The commonest dividing cells are your gut lining. So you get mucositis, and you only have to have VRE sitting in your poo, and it immediately transgresses into your bloodstream and you get bacteremic. On the other hand, if you're talking about otherwise healthy people, well then usually they'll get bacteremic from a urinary tract or something like that. So it depends on the population. So why do we worry about VRE, and why are we sort of paying attention to it and arguing with others who claim, a number who claim it's not worth tracking, are getting fewer and fewer. Well, of course, at the Austin we have a liver transplant unit, and in many ways this is these are like the canaries in the coal mine in terms of identifying whether you have multi-drug resistant problems. These patients all have liver failure, they've all had multiple infections, they've often been primed with umpteen different courses of antibiotics to save their life. They then have a transplant which involves surgery involving their gut, so if they're colonised with VRE pre-transplant, they will be, once you're colonised in your gut flora, you will be colonised more or less for life unless you're otherwise healthy. And so, of course, with the surgery, they often become bacteremic. And amongst that population, at least, there's a 30% attributable mortality to VRE. Most strains are pretty difficult to treat. They're often resistant to standard drugs, as I mentioned already, ampicillin, penicillin, and they're often high-level resistant to gentamicin. So the synergy that we would usually get with a combination of a cell wall active agent like penicillin and something that's going to work on the ribosome like gentamicin, that synergy you get is not available to you to try and cure the patient. You can use other drugs I've already mentioned, ticaplanin, linezolid, very expensive, $125 a dose, so $250 a day for therapy, and within 2 weeks 60% will have anemia or neutropenia from that. And then there's other new drugs such as daptomycin, which also has side effects like myositis and very expensive. It's very easy now in infectious disease when we're treating VRE to readily spend $500 to $1,000 a day on antibiotics and other agents. So these are your taxes, or maybe not your taxes, but soon your taxes at work, and this is a major, apart from the suffering, this causes a huge financial issue. So why do we screen for VRE colonisation? Well, largely because we want to work out what that, whether it's 20 to 1 or 10 to 1 or whatever, and we know that if we can identify those who are colonised in their gut or prevent them from becoming colonised, that will stop them from then later developing infection. So we screen for those patients who we want to know for their own self-protection, that is those who are immunocompromised, like the transplant patients or intensive care unit patients, where if we knew that they were colonised and then they became febrile, that would alter the empiric antibiotics that we would start. So that's a good example is our transplant patients, that if someone's about to have a liver transplant and they become febrile post-op, their antibiotics are different if we know they're VRE colonised pre-transplant than otherwise. Alternatively, if someone's VRE colonised, we want to protect the herd, in other words, the rest of the hospital, from that person then disseminating VRE through the hospital to the immunocompromised population. So, you can go up to our liver transplant unit, and amongst those patients or any elderly patient who's confused and they're walking down the corridor with dropping faeces behind them on the floor, we try and avoid this, but it is a hospital and that's what actually happens. You can imagine the infection control risk that poses, and we need to know whether that person is spreading VRE down the corridor and what we should do about it. So at the Austin, just for instance, we screen our renal unit, our liver transplant unit, our ICU, and we screen with rectal swabs. So we say, welcome to the Austin, bend over, straight up the arse. And then once a week they get a rectal swab so that we know who's positive on admission and then who has become positive since admission, so we know whether we're giving it to them or whether they've got it already. Where we get faeces sent to the lab, obviously enterococcus doesn't cause diarrhoea, but if we're getting a diarrheal specimen for other reasons, then we screen it for VRE, because if you've got diarrhoea, then you're a potential infection control risk to the rest of the ward. And so we routine, and then if we find someone's positive, we screen those around them. Now, I've already kind of mentioned how do you acquire different pathogens, but obviously if we just talk specifically about VRE, well, you can either catch someone else's strain or you can create your own. And a fair bit of research has been done to identify what proportion of each of these is relevant to enterococcus. So, for instance, enterococcus for VRE, what makes you more likely to acquire someone else's strain is if there's poor infection control, overcrowding, use of third-generation cephalosporins like ceftriaxone and other antibiotics. And of course, that's usually monoclonal. And there was a key paper by Alex Pediglione, who's now down at the Alfred, who did his PhD with me, where he actually looked at the various risk factors at the Alfred, Austin and Monash associated with the emergence of VRE. And this was a terrific study. It was incredibly hard-working, tracked all these patients for over a year and a half, looked at their isolates, showed that they were largely monoclonal, that where they were acquiring, for patients who are generating their own strain, that was occurring at day 12 to 14 after certain antibiotics were being used, but otherwise, if they're catching them from someone else, then they were largely monoclonal, whereas if you're generating your own, you might expect that they're all polyclonal, those are all genetically slightly different. So it's a lot of hard work. So, and as the alternative is this idea that you generate your own strain, and in Australia at least, most of our strains are Van B VRE, and something that I'm just going to discuss over the next couple of slides is the complexity of this, and why is it that in Australia it's largely Van B VRE, whereas in America it's largely Van A VRE? Well, probably because in America it's largely to do with poor infection control and cross-transmission in hospitals. In Australia, it's what we found in our labs and with various research, that in fact naturally occurring gut anaerobes carry this Van B gene, and that with sufficient disruption the gene jumps out of enterococcus into healthy, otherwise sensitive enterococcus and turns them into VRE. And that this can be prompted along by use of certain antibiotics that disrupt anaerobes more to a great degree. And this is something that Alex showed in his study, that ticacillin, clavulanate and meropenem are particularly relevant to this. And so this is where the collaborations sort of come in. So you've got Alex doing his clinical study, we've got Paul Johnson and Libby Grapsch, our infection control scientist here, and Ben Howden in our department, linking in with Tim Stinier, who works at the Department of Microbiology and Immunology here at Melbourne Uni, to say, well, we start to collect the isolates and then look at the different genetic fingerprints of these strains and also the resistance mechanisms. And it's through collaborations like this, clinical and laboratory collaborations, that we've been able to make some headway. And Tim couldn't have done it without us, and we couldn't have done it without Tim. So this is a landmark, actually it was a research letter to the Lancet a few years ago, back in 2001, where Tim was at Monash at that time, and we were looking at a way to try and identify VRE carriage in patients using PCR off their poo. And we kept finding all these patients who were positive for Van B genes, but we couldn't grow the VRE. And in the end, to cut a long story short, what we found was that there was a whole lot of Van B genes in their poo, but it wasn't in enterococcus. It was in naturally occurring so-called good bacteria. And so this was published in the Lancet. It was, well, I'm biased, but I think it's a landmark issue. It has been cited many times. But subsequently, Sue Ballard in our lab, along with Tim, identified all these various naturally occurring gut anaerobes that all of us carry in our gut, that all of them carried Van B gene, which when you sequenced it, was identical to the Van B gene in VRE. So in other words, it is normal for us to carry Van B genes. The question is that they're normally not in enterococcus. That's the problem. And if we're going to generate our own strains, it's usually that we've buggered up those anaerobes, they've spat out the gene, and then it's entered a normal enterococcus and turned it into VRE. So this would fit nicely with Alex's clinical study, where he had correlated the emergence of VRE with certain antibiotics. Well, it happens that those antibiotics act a lot on anaerobes and disrupt them inappropriately. And so the story made sense. Now, subsequently, other groups, well, first of all, we then linked in with Thierry Lambert at the Pasteur, sent him some of our anaerobic strains. He then put them into notobiotic mouse, and mice were able to show that the genes, at least in mice, did jump from these anaerobes into enterococcus and to develop Van B VRE. And we're in the process now, we just have an NHMRC grant looking at that now clinically in real time with patients who are admitted to the Austin Hospital following their vancomycin-susceptible enterococci, tracking their molecular subtype, and then seeing when they develop VRE and whether or not it's the same strain, VSE, vanc-sensitive enterococcus, that has become VRE. So this same phenomenon now has been identified by others in Canada and Massachusetts. You'll see that they talk about between 2 and 6% of people carrying Van B genes. Ruminococcus, there's even this paper from Bacillus. And if you look at other species that there are these bugs in the soil that have been found to carry VAN-B genes. And it might be, this would be no surprise, because vancomycin, the antibiotic vancomycin, was developed, actually it used to be called Mississippi mud, because it was developed from bacteria that were initially found in the environment, and it was a naturally secreted compound from these bacteria. So you might expect that through evolution that other bugs out in the soil and so forth in the environment would have learned to become resistant and develop their own VAN-B genes to combat this. So we, Marisa Graham, who's now a microbiologist, but when she was a registrar with us, we decided that it might be interesting to see, well, what is the carriage rate of VAN-B genes in humans throughout their lifetime, and does it change with the food source that you eat? And how relevant is that if we were to try and move to a rapid molecular-based method of detecting VRE carriage or VAN carriage in humans? And so Marisa did a pretty tough experiment. We went out to all the Rotary clubs and everything around the Austin and asked for healthy volunteers to donate fecal specimens, not the sort of PhD you might be thinking about if you're looking at some molecular thing, but actually it's a very special collection. And then she went to a preschool where all the kids were breastfed. They had never started eating solid foods, and collected their faeces with the view being, well, maybe these anaerobes, you know, our guts, I don't know if any of you got kids, but when the kids shit in their nappies, it does not smell when they're breastfed. It's only when they start eating food that their faeces starts to smell like the bad smell that we associate with faeces. And so something changes in our gut with our food intake. So basically Marisa collected faeces from 57 breastfed children, never been solid fed, 97 healthy adults, if you call Rotarians healthy, I guess most of them are. And then we looked at hemodialysis patients, 50 hemodialysis patients, and they're important because they often get treated with antibiotics. So we actually expected a major difference between healthy adults and hemodialysis patients. Well, what you can see here is that none of the kids were VRE positive, but 33% of them, close enough, had VAN-B genes, even at the age of 2 to 3 years of age in their poo, compared to 70-odd% for healthy adults and a similar percentage, statistically similar, for hemodialysis. So we were actually surprised. We were not surprised that there was a difference between kids and adults, but we thought the hemodialysis patients would be kind of worse because they've been more exposed to antibiotics. Did we go back to these healthy adults and say, well, how many antibiotics have you been? Yes, we did, but only in the few weeks before their poo was collected. And I guess this, you know, maybe the antibiotics are irrelevant. It's about what your gut becomes colonised with across your lifetime. So this has implications. You know, this is an important study because it showed that PCR of poo was a relatively useless test in the hospital, because we were going to get 3/4, somewhere between 2/3 and 3/4 popping up positive on PCR, when in fact hardly any of them, only a couple, had actually had VRE there. Now we could have missed the VRE, but we didn't, you know, looked as hard as we possibly could, or anyone could, and couldn't find it. So this has implications. Why? Well, because the culture for VRE takes 3 to 4 days. And in that 3 to 4 days, that patient had moved from ward to ward to ward to ward, gone down to the CAF, crapped everywhere, spread whatever they're going to do, and then we come along and say, you've got VRE, you've got to go into a single room and we're going to put on gowns and gloves, and everyone says, well, that doesn't make any sense. And of course it doesn't make any sense. And so that's why we've moved towards a sort of practical issues towards controlling VRE in this hospital, in our hospital, and just I'm going to skip through these because they're perhaps a little less relevant, but this just shows you that by taking this sort of so-called search and destroy policy, but not being able to use a rapid method like PCR to identify who's at risk, we were losing the battle at the Austin. So here is our MRSA rate, steadily coming down with the introduction of alcohol-based hand rubs since 2003. 2002 we had 62 patients at the Austin with MRSA bacteremia. Last year we had 6. Okay, each one cost $25,000 and about a quarter of them died. So big impact with a simple intervention with MRSA. And here is our VSE rate, pretty stable, in fact statistically stable, because most of them come in from the community. And here's our VRE rate. So despite all our efforts, we were still losing the battle in the hospital. So This was despite, wearing gowns and gloves like the Centres for Disease Control tell us, putting patients in single rooms, but when we finally identified them, a very high-profile hand hygiene program, cleaning of VR rooms in a special way, antimicrobial stewardship, and a very intense surveillance program, which many other hospitals don't have. And so, in essence, we're still seeing increasing rates of VRE disease because of this delay. And we knew that there was environmental contamination, things like the weigh chair, the bed rails, the call button. Often in VRE positive rooms we would find VRE on these items. Here's the chair in the visitor's waiting room. Now I can tell you this is not coffee, and in fact it's pretty much solid glycocalyx of enterococcus and faeces. And so the question is whether this is the visitor's waiting room or whether it's a PCR booth for enterococcus. So just to skip through this, I guess what we decided in the end was to say understanding about the transmission of this bug and how to manage it was important in how to approach it. And so what we decided to do was to say, well, why don't we just treat the entire hospital like it's VRE contaminated? And yes, we'll keep screening, but we should treat everyone as though they're positive. And the key kind of sump or battery of infection, the septic tank, is the environment. And that all these, if you're sick and you're in the Austin, you have to be weighed every day on that chair, and it's just a matter of lottery whether the person before you has VRE and then you sit on that chair and it hasn't been cleaned properly, or whether you're the first. And so, on the other hand, if we use cleaning agents that got rid of VRE, but also potentially got rid of these anaerobes, these spore-producing anaerobes that carry these genes naturally. So the issue is not so, one is about whether VRE is spreading around the hospital, the other is whether there's VAN-B gene contamination of the hospital, and whether we should look at it from that point of view. So just for the next, this is our increase in our VRE problem. So we decided, we'd already had a preliminary run in our hemodialysis unit where bleach is a fabulous product, and we know that from HIV. I mean, it kills everything. And 1,000 parts per million is very effective for all spores, as well as norovirus, as well as HIV blood spills, everything. The problem, in our hemodialysis unit, we'd started using it routinely everywhere as the only cleaning agent. And with that, we'd been able to downgrade the use of long-sleeve gowns and so forth, and simplify things, and had very, very low VRE transmission rates. And it was associated with great simplicity for the cleaners, as some practical issues plus reduced transmission. So we thought, well, what about if and we knew that these super cleans with 1,000 parts per million bleach had a big impact in reducing VRE. So we decided to convert the whole hospital to only cleaning with bleach. Now you might say that's a simple thing, but there are lots of issues in a hospital of 10,000 employees and getting the cleaners to change, and a lot of health and safety issues. I mean, for instance, you can't mix bleach in warm water. Why? Because it vaporises. It should be mixed in cold water, and it vaporises and you get chlorine in your eyes and you get side effects from that, and then it's not 1,000 parts per million anymore, it's only 50 parts per million. So it's got to be in cold water, you have to alter things. So there's a whole lot of technical things which I won't take up time now. Also, I would say our cleaners in the hospital and throughout Victoria can be performance assessed but not performance appraised. What does that mean? They can't be sacked for doing a crappy job. They're about the only workforce who can't be. But in fact, most of them, and I keep saying this, that for our cleaners now are the lowest paid, least educated. And yet at Fairfield Hospital, where Mark and I trained, they were considered as one of the key personnel in the hospital. Well, now 10% of our cleaners at the Austin are illiterate in any language. You cannot give them written material, you must explain it verbally. And it's not their fault, they're all well-meaning good people, but it's the degradation in what society perceives as the importance of this group. And yet, by empowering them and explaining this to them, they really come on board with this. So we've installed all these new mixing devices that automatically mix 1,000 parts per million. We've measured the length of the hose, so it goes so many centimetres down below the edge of the bucket and doesn't splash. It only mixes with cold water. We've actually used the savings from this to a point where we've had some savings in terms of changing our gowns and gloves, so we're no longer following the CDC protocol. We've shown that alcohol hand rub works against VRE, and with that we've appointed cleaning supervisors to actually go around and teach people how to clean properly and to explain to them the importance of why we need to screen for VRE in the environment. And so we assess this both in terms of colonisation and disease. Before and after the intervention, we had an intervention period prospectively from February 2009 through January 11, and I'll just skip through this briefly. So we looked at newly acquired VRE colonisation as well as the sort of burden, that is old, previously colonised plus new colonised. We looked at colonisation rates at the time of admission, where they just more were coming in with it, and then we calculated these things, and then we looked at disease in terms of bacteremia. So here's the activity for our high-risk wards. Often our nurses, so this is the activity per week across the 18 months with the intervention period here, where there's no data. And so the nurses were constantly saying, look, of course we've got more problems with VRE because we're working harder. Well, actually that's true. So we were able to measure the fact that per week in the high-risk wards in period A, before the intervention, they had an average of 219 patients, and by the end they were managing 230. So they were working harder. Were we screening harder? Well, yes, we actually were screening. So 68% of those people who should have got a rectal swab on admission at weekly got it when they were meant to before the intervention. But by the end it went up about statistically significantly, between 72 and 74. So if we should be seeing more colonised patients because we're looking harder, right? Well, in fact, the opposite was true. So here is our pre-intervention colonisation rate, 10 per 100. Every 100 patients we screened, 10.7 of them were positive. During the first 6 months after the intervention, it dropped to 8.5, statistically significant, and then down to 6.7. So this overall, this was a 1/3 reduction in the rate of colonisation in the hospital with VRE. If we look at the total burden for the first time, it actually went down during that period. Now, some of our patients, the only way you can reduce burden is to kill the patient, make them go to another hospital, not come back to your hospital some way either because they're dead or they don't want to come back, or they're actually a bit better. We didn't kill any more patients than normal. Some do die, of course. But the point was that the burden for the first time reduced. And so if you look at VRE colonisation, well, how many were colonised on admission? Number of patients screened on admission. So what was the overall rate? Well, actually it stayed pretty stable during that time. So about 3% of patients were coming in with it. We weren't giving it to them. The rest we were giving it to during that period. And then if you look at disease outcome, well, in fact, the 6 months prior to the intervention, 14 had bacteremia. During the 12 months after, there was 5, and this was significant, whereas if you compare, so highly significant as a rate. If you standardise that against the vancomycin-susceptible bacteremia, which mostly is community-acquired, then you can see that in fact during that period it didn't change, 0.54 statistically. So we had a stable VSE rate, because it's largely community, that's from our normal healthy enterococci if you like, but we had a reduction in disease rates from VRE. And similarly for environmental contamination, the bleach program seemed to work. So what are the conclusions? Well, it seemed that this multimodal bleach intervention was effective, that there was about a 1/3 reduction in VRE colonisation rates. It stabilised at least or slightly reduced the burden, and there was reduced inpatient acquisition, and this was borne out in terms of our disease rates here. And then so we had actually a 70+% reduction in our VRE bacteremia rate. So potentially a paradigm shift. What are the last couple of minutes? What are the other key things which could also help improve this? Well, of course, how does VRE spread in the environment? Well, it's through poo and contamination of the environment largely, and then spread of that environment with your hands and other shared bits of equipment. And so improved hospital design would help. And so really there's one basic motto that you could learn from this. Hospitals are like giant PCR machines, really. They just take a couple of genomes and then spread it amongst all the others and multiply it up. So we could start with this simple philosophy of a patient to toilet ratio, and that is one bum, or maybe it's a bum like that, per toilet. And that would help a lot. But currently, you know, the Austin in Melbourne has 1/3 of its beds are single rooms, each with its own bathroom. Places like the Royal Melbourne, my guess is you've probably got about 5 to 10% of the beds with their own bathrooms. The new hospitals, such as Royal Perth and Royal Adelaide, are all now 80 to 85% single rooms per, you know, so they've got mostly single rooms, and I think that's a very important initiative. So the rule of one bum per toilet, I think, is a good one. And then finally, of course, we're not going to talk about today, but tightening antibiotic control is important. We are definitely in a situation of antibiotic overload. This primes the whole scenario about acquiring other superbugs and disrupting your healthy bugs, as I've just been describing. That's a topic for another talk. So what we've talked about today is the view from Mars and the big picture. It's pretty important. If you were looking down on the human race, you'd say that we're largely a bunch of dickheads. That we need to understand the basic epidemiology and mechanisms of the problem, and this provides guidance in how to identify the solutions. And the clinical and research links are often crucial and very synergistic. You know, the sum of the two is much greater than the components individually. And so it really, you know, in this case, it started with a bed and then gone to the bench and then back to the bed. And that the implementation of practical solutions are, you know, often not so easy, and trying to get things changing, workforce practices and so forth, can be a problem. But the clinical confirmation obviously can be difficult too, because there are often lots of confounders, but it can be done. So Mark, at that point I'll stop, and I'm happy to take any questions. Thanks.
Questions for Lindsay? I'll start by, oh sorry, yeah.
Sorry. So you mentioned in the newer hospitals that they've got ratios of, you know, one toilet per room and whatnot. Have they done any of these types of analyses where they've tested whether, you know, VRE reductions or infections are reduced?
With the change in bed ratios?
Yeah.
Well, to be honest, no. The short answer is no, because until these, you know, until now, like the Austin's the best at 30%. Now, the majority of those single rooms are taken up with dying patients. You know, they come in, they're dying, and so they're given a single room for some privacy. We've, in the last 2 years, started up sort of like a control tower idea, where every morning the infection control nurses have every bed in the hospital listed, who's got VRE, who's got MRSA, who's got C. diff. And we've had a policy change in the hospital that infectious disease has first call on the single rooms ahead of any other reason. Makes sense. You know, stop people dying first and then worry about the ones who are dying later, I guess. But we haven't been able to analyse that, you know, because it's just so chaotic. We run at 99% capacity all the time. And in fact, recent survey of patients shows that if you're in our hospital for 4 days, you will have moved beds 3 times in 4 days. And Royal Melbourne, everywhere will be the same. So you come into one place and then shuffle off, you know, you get someone into the, I mean, it's just the way the hospital works. So the reason why that analysis, it's been too confounded with all these various issues. I think it's going to be very important for these new institutions where they have a majority of single beds that we do that sort of analysis. Having said that, there's so much circumstantial evidence for, you know, patients where we've found their VRE colonised, we've gone back and looked at the environment where they've been sharing the bathroom, the whole bathrooms prior to us using the bleach program, just assuming everything's dirty, you know, we'd find VRE everywhere, and you could, the rate of you, if you were lying in the bed next to the patient who had VRE, your chance of having VRE after 3 days was, you know, 60%, having acquired it. So you can see that you almost had to bring in, we would more or less just said, look, we're not going to follow CDC anymore, it's failing in this situation, we're going to just assume everything's dirty. Now our professor of medicine said, you know, Lindsay, this means the hospitals will smell like they used to in 1980. And I said, yes, Jeff, you know, remember what it used to be before we had VRE? So, you know, of course, there is a bit of a back to the future about this. And, you know, there's been some concern that using concentrated bleach like this will lead to degradation of the chairs and so forth, and it's true, it does. But usually what we've found, at least in the dialysis unit, is by the time the vinyl's being affected by the bleach, the chairs were already torn from being knocked and they needed to be changed. Those chairs I showed you with the so-called coffee stains, well, you know, they were from the brand when our new hospital started 4 years ago, all chosen by an interior designer because of their colours and all the rest, but no consultation with us. They've all now been replaced by vinyl chairs. So, you know, pretty things aren't necessarily practical.
Have you complemented those studies by actually doing environmental testing, pre and post intervention?
Yeah. So I didn't show, I skipped through the slide, but actually the rate of environmental contamination we know that it'll be high in VRE positive rooms, but in VRE negative rooms, that the rate was statistically significantly reduced with the introduction of the bleach program. And I guess what we're now moving towards is to use developing Andrew Marnie as part of his PhD, and Sue Ballard, who's our PhD postdoc, are looking at a rapid PCR-based method for environmental testing. So the idea is that the cleaners will clean with bleach product in the morning. After they've cleaned, there'll be a swab of the environment. If we waited on culture, it'd take 2 days, or 3 patients would have already been in that room by that stage. But using the PCR method, at least the answer will be there the next morning, and so there's a sort of an outcome marker of how well they're cleaned. Yep.
So you said if you're a patient next to a VRE sick patient, your risk of being colonised is 60%.
It varies on how long you've been exposed. And,
What about your staff? Are they being tested and swabbed?
It's a good question. No, they haven't been, because firstly, we assume they're continent, the staff. Secondly, that they wash their hands. And thirdly, we wouldn't know what to do with them if they were positive. I mean, that's a really key question. So, and it's different, and it's why different pathogens vary. So for MRSA, for instance, we swab our staff. If we have an outbreak, we swab our staff, their nose and their axilla and groin for cutaneous colonisation. But if they're positive, we know that we can give them chlorhexidine body wash and mupirocin nasal ointment and clear their carriage. But at this stage, there's nothing that's been shown to clear VRE carriage. I mean, usually just eating normal food and having a normal immune system, VRE in itself has a survival disadvantage, and so your healthy gut flora will at least reduce its numbers so they're undetectable in our systems. So for staff, though, we haven't screened them for that reason, but also they're in a low-risk group because we expect them to be washing their hands and to toileting properly. It's a different matter for patients because their medical conditions often result in them being incontinent or soiling of the sheets and so forth. So that's the reason.
Are you surprised that you've got like 70% of patients actually having Van B in their anaerobes, but yet your intervention had so much impact? I mean, I suppose that's an indictment on the hospital, which can transmit VRE much better than an anaerobe can actually shift its genetic material to enterococcus.
Yeah, I mean, I guess it's then adding to that the fact that the patients who are in the hospital are getting antibiotics and disrupting their anaerobes, and so it's a complex issue. But I think the hospital is incredibly effective at transmitting these bugs, and it's not just I'm showing all the data from the Austin, but you can look at other bacteria like Acinetobacter. There's a huge outbreak down in the ICU at the Alfred after when the Bali burns victims came back. Many of them were colonised with multi-drug resistant pathogens from Bali. It's in the water supply up there, and their wounds were getting dressed and so forth. And so the burns unit at the Alfred, as did all burns units around Australia, had major problems with Acinetobacter and to some extent Pseudomonas, which was multi-drug resistant. And it took them years to clear it out of there, and it was all in the environment, So I think, if you cluster sick patients together, it will find out every little flaw in your control mechanism. And unfortunately, this is an issue that's an ongoing debate you hear in the press, and that is that hospitals these days all their outcome measures are about throughput. They're all about quantity, not about quality. It's quantity of throughput, it's quantity of dollars, And how do you measure the quality? Well, most of the quality is measured by bad things, infection rates or whatever. It's not actually measured by good things, whereas if you talk to the patients, they're the good things are the things they remember. So, I mean, I'm not saying we shouldn't measure the bad things. What I'm just saying is, how do you separate out infection rates when, you know, the Austin Hospital, since it was built, the attendance at the Austin, at our emergency department has gone up 45% in 4 years, above what it was ever designed to cope with. Why? Because we're a growing population. So, you know, it's not like everything's staying stable, you know. But I think that is a problem, and it's a debate that as a society we need to have. It's off the point of this talk, but a heck of a lot of our energy is spent managing patients in hospital, often where that care is futile. And, you know, obviously there are many where it's not futile, the transplants and all those other things. But if you look at the generation of multi-drug resistance, and we're about to start a study at the Austin looking at this, what's the volume of antibiotics and the potential dissemination potential of these patients where essentially their care is futile. And in fact, in many cases, if you ask them, do you want all this care? They would say, I don't want to go to ICU. I want to die a dignified death. But the current process makes it hard for them to actually do that. So the automatic thing when you come to the hospital is to save your life. And until, you know, as a clear example, my own parents spent a lot of money signing forms saying they didn't want to have resuscitation measures if they got sick. But when my dad had a stroke, the hospital said, we don't recognise this. And we're going to do whatever we can. You know, I was able to intervene, but most people can't. And I think that's why Bill Sylvester's program at the Austin, Respecting Patient Choices, which is now designing a legal document which is valid and accepted throughout all states of Australia, that people, when they're feeling well and can make a legitimate choice about how they want to be cared for, they can sign that and that's legally binding and can't be interfered with by relatives who are perhaps feeling guilty because they haven't seen their mum for 10 years and coming in and want, quotes, everything done, when in fact the patient doesn't want all that done and doesn't want all this stuff done to them. It's a very important social thing, but it's completely different. It's off the topic of this, but it's relevant in terms of usage of dollars and generation of resistance.
Just with respect to the amount of dollars, I'm just wondering if you're saving money for the hospital, for the taxpayer, or conversely, how much has this transition, the intervention that we talked about, cost? Has it been more expensive or less expensive? How much expensive is, you know, bleach compared to the previous agency?
Thanks. Yeah, well, so it has saved money, or at least broken. It's broken even in terms of its implementation cost, and where it's saved money is instead of having, you know, 14 patients with bacteremia, each costing $25,000, we've only had five a year. And of course, but you know, that gets complex because actually those 22 of them, about half died. Dead patients are very cheap, you know, because you get sick, you die, and so you don't cost any money. Whereas if you salvage them, they actually cost money because they're filling the hospital and you're giving them... I know this sounds weird, but this is how the system works. And of course, on the other hand, the ones who die quick, well, they clear the bed and then you get a new patient in there and that new patient's costing you money. So economics gets pretty weird quickly, and kind of you start to wonder what you're listening to. You know, when you hear these people talking, I know because I'm talking to the relatives and I know what I care about, and it's not the money. But so to answer your question though, the bleach program, and we were able to hire all those supervisors and introduce the bleach, and at the very most it cost an extra $25,000 for the hospital across the entire year on a budget of $360 million, and yet it saved about 20 odd people from getting bacteremia. In the case of alcohol-based hand rub for staff, there's been lots of studies on that in various hospitals in Victoria, and you save about $2 for every $1 spent. So the introduction of alcohol-based hand rub in the hospitals to maintain the program in our hospital costs $3.40 to $3.60 per patient, not per day, for the whole of their admission. So I don't know, what's a Big Mac? It's about 2/3 the price of a Big Mac. I think we were last worked out, whatever, they change a bit, you know, there's a Big Mac index. But so for about 2/3 the price of a Big Mac, we can run our alcohol-based hand rub program, and more than half the rate of MRSA bacteremia in our hospital. startup costs are more, and so forth. But so across the system, it saves the healthcare system a lot of money. On the other hand, well, I suppose what it means is that means our hospitals are more efficient. We're not having to build a new hospital because we're making better use of the beds that we've already got. I guess for this audience, though, just to come back to Mark's starting point, none of this would be possible if it weren't for this sort of interlink between the clinicians and the lab. And I guess for those of you who are thinking of doing PhDs or are already doing PhDs but interested in another project, then come and talk to us. We're very interested in getting enthusiastic people to help with these things. And clearly you can see that things like rapid diagnosis of carriage or rapid diagnosis of disease can make a huge difference at the coalface in terms of patient management and control of the disease.
So if you have other questions, please join Lindsay for lunch and he'll try and recruit you. But thank you.
Coffee's pretty good out where we are. So.
Thank you very much for an incredibly informative lecture, but also really entertaining. So thank you.